Hello, everyone. My name is Abi Allure, and I'm a fourth year medical student at the University of Louisville. My mentor is Dr. Swapna Chandran, who is an otolaryngologist in the Department of Otolaryngology, Head and Neck Surgery. Today, I will present to you about my clinical vignette called Management of Hoarseness, a Case of Reflux Laryngitis, LPR, and Gastroesophageal Reflux Disease, GERD. Hoarseness in patients can prompt workup for potential malignancy of the head and neck, but oftentimes may just denote a reflux process. LPR is a frequent cause of hoarseness, chronic cough, and globus sensation. It is important to distinguish the overlap and discrepancies between LPR and GERD. My case today is about a 74-year-old male with a history of GERD who was referred to ENT clinic due to 4 months of hoarseness, globus sensation, sore throat, and worsening reflux. The patient had been taking pantoprazole for years, but continued to experience his reflux symptoms. Initial physical exam upon laryngoscope showed mild vocal fold edema, arytenoid erythema, and thick endolaryngeal mucus. And you can see some of these findings here below in some pictures. Some hypertrophy, you have some generalized erythema, some arytenoid erythema, and just edema overall and irritation. An outpatient consult thereafter diagnosed the patient with GERD refractory to medical therapy, ruled out hiatal hernia, and confirmed high acidity in the esophagus. The patient deferred surgical management and preferred medical treatment. So in clinic, his pantoprazole dose was increased to twice daily. He was started on famotidine at night additionally, and follow-up 3 months later showed that his reflux symptoms and hoarseness had resolved. And physical exam with laryngoscope at that time confirmed improvement in laryngeal reflux. This case demonstrates the importance of understanding the relationship between LPR and GERD. When just talking about LPR, it's important to understand that it only requires a minor acid exposure to the larynx to cause irritation. Heartburn is rarely present, reflux is during daytime, while upright, or during exercise, and it's more of an upper esophageal dysfunction, causing the throat symptoms that I described before, globus sensation, hoarseness, sore throat, etc., versus GERD, which is a lower esophageal dysfunction, causing epigastric and esophageal symptoms, which includes heartburn, which is commonly present in GERD all the time. Additionally, GERD requires prolonged acid exposure to the esophagus, refluxes during the nighttime, and the laryngeal symptoms are present sometimes. When talking about treatment, diet modifications and proton pump inhibitors, PPIs, are the gold standard for both LPR and GERD. Studies have shown that omeprazole decreases laryngeal and esophageal symptoms and improves erythema and edema on laryngoscopy by more than 60% in some cases. When a patient comes in with hoarseness, it's important to distinguish whether their hoarseness is from LPR or GERD, and whether or not medical treatment or surgical treatment will be best for them. So treatment must involve a patient-centered discussion to determine the best route to go moving forward. And if they choose the medical route, it is important to monitor patients regularly for medication dose adjustments. Thank you very much for listening to my case presentation.